Okay, welcome everybody to the University of Michigan Concussion Center Journal Club. For those of you who are joining us for the first time, my name is Steve Brolio. I'm director of the Michigan Concussion Center. We're excited that you've joined us for today's discussion on the most recent consensus statement on sport concussion. Before we get started, I have a couple housekeeping items. Today's session is being recorded. If you're in need of CME credits, the link to claim them was in the email announcement for today's talk. If you're in need of BOC CEU credits, we'll be sending an email out on how to claim them after today. Because of the large number of attendees today, we're not able to have an open discussion, but we're happy to take your questions for our host or guest. Feel free to drop those in the Q&A section at the bottom of your screen. Today's hosts are Adrian Boltz and Reed Searduk. Both are doctoral students here at the University of Michigan Concussion Center. And we are joined today by Dr. Jon Patricios. Jon has been in sports medicine practice for 28 years. He is currently director of the Waterfall Sports Orthopaedic Surgery in Johannesburg, South Africa, a professor in the Faculty of Health Sciences at the University of Witwatersrand, where he leads the Wits Sports and Health Research Group. Jon is founder and director of Sports Concussion South Africa, sports concussion consultant to the World Rugby, and a board member of the International Concussion and Sport Group, co-chair of the Scientific Committee for the International Consensus Conference on Concussion in Sport, and lead author of the most recent consensus statement. Most recently, he was on the Independent Concussion Advisory Panel for FIFA 2022 World Cup, and in 2023, he joined the Union of European Football Association's Head Injury Advisory Committee. Jon also serves as an editor for the British Journal of Sports Medicine and served 2 terms as president of the South African Sports Medicine Association. Jon has been a team physician to school, club, provincial, and international sports teams in rugby, cricket, soccer, athletics, and basketball. Jon, welcome to our Journal Club. We really appreciate you being here today and working through some of your tech difficulties, but I'm going to turn it over to Reed right now to run our session. Reed, take it away.
Great, thank you, Steve. We're just going to get our slides going here. Perfect, thank you. So good morning and good afternoon to those joining us overseas. Welcome to the Michigan Concussion Center's and Neurosport Journal Club for a very special edition. So today we'll be discussing the 6th consensus statement on concussion in sport, which was recently published in the British Journal of Sports Medicine and was led by our guest, Dr. Jon Patricios. Needless to say, we're particularly excited to have him here. So long list of authors here. Thankfully, we have some of our special guests joining us today, and we can progress to the outline for today's discussion. So here on the right side, I just have a QR code for those who were unable to access the article previously. You can just scan that and pull it up on your device. And today's outline will include an introduction of the statement, the updated definition, talking about injury prevention strategies, the SCAT-6 and the brand new SCOT-6, return to learn and return to sport strategies, clinical biomarkers, retirement, and future directions. We do, however, acknowledge that every component of the consensus document is significant, but to cater to the clinician in the short term, we will only be discussing these components today. Sorry, there we go. So to lay out the remaining hour, I just want to give a brief overview of what a consensus statement actually is and what the 6th consensus statement aims to do. As you might have guessed, this is the 6th iteration of the document, the first being released in 2001. So over 2 decades strong and hopefully many more years in the future. These sentences you see here are taken directly from the intro of the statement, showing that this consensus statement reflects the current literature and clinical recommendations regarding sport-related concussion. I will emphasize the word recommendation, as this is not a diagnostic tool, but rather aims to inform clinicians in their management of sport-related concussion. Importantly, the Concussion and Sport Group acknowledges that this statement is a representation of the current literature that will undoubtedly evolve and progress over the coming years. Further, although this consensus statement is the star of the show, It is to be read with the 10 accompanying systematic reviews, focusing on specific domains within concussion, all led by world-renowned scientists across the globe. Thank you. As you can see here, it's a long process to come up with a new consensus statement, much less one with such a wide scope as sport-related concussion. It clearly does not happen overnight. Rather, it is the product of years of processes that are overseen by lead authors of their respective systematic reviews and the ultimate consensus statement. We see the process starts with appointing co-chairs and creating scientific committees, progressing to writing systematic reviews, ultimately ending up with the conference in Amsterdam, and then finally, as we saw in June of this year, the publishing of the statement in the British Journal of Sports Medicine. Unsurprisingly, as I'm sure we're all tired of hearing about, the COVID-19 pandemic was a large hurdle that the Concussion in Sport group ultimately overcame to be able to host an in-person gathering of everyone involved with the sixth consensus statement and to present its findings to the world. We see here the amount of effort and planning that goes into such a document is no small feat. And Jon, not to put you on the spot here, but if you wouldn't mind just talking a little bit about how, if you're not too sick of hearing about it, how maybe the pandemic kind of changed the process. I'm sure this wasn't a typical year compared to previous editions. If you wouldn't mind just giving us a bit of insight on that, please.
Good morning, everybody. Thank you so much for the invitation. Firstly, it's a great pleasure to be with you. So to cut straight into it, thank you for the direct question. I think it's a very valid one. So essentially, the planning was to hold this consensus conference and to publish the work in 2020, which would have been 4 years after the Berlin conference, which is the normal cycle. We were right in the heart of the pandemic at that stage. And so as we approached that date, we realized it wouldn't be viable, and we put it out by a year to 2021. Interestingly, the original venue was Paris. It was scheduled there. And as we got closer to 2021, we realized that travel hadn't opened up yet. It was variable across the globe. America had opened up. Australia was very stringent and wouldn't allow any travel. And central to this decision was the scientific committee's view that this was a meeting that needed in-person attendance. It needed people to present, it needed people to question, it needed floor participation, it needed an in-room consensus panel discussion, and it needed workshopping. So, for it to be viable, we weren't going to be able to do it virtually. Moreover, the participation from across the globe made a virtual meeting almost impossible. You would have to be up at 4 a.m. in Australia and at 10, 11 p.m. in other parts of the world. So it was a huge logistical challenge. 2021 came and went, and we realized that wasn't possible. And so we pushed it out to 2022. And to make things even more interesting, when we went to our venue, our chosen venue in Paris, they were now closed for renovations for the upcoming Olympic Games, which, as you know, is taking place next year. So many of the hotels were closed for renovations. The venue wasn't available. So we had to look elsewhere. And we settled on Amsterdam, the organizing committee. So that's just in a nutshell how that impacted, and it just gives some idea of some of the logistical issues. From a scientific perspective, we'd already conducted one set of reviews, systematic reviews and data extraction. And so as a result of the delays, we had to have a second round of reviews of updated literature and further data extraction. So it actually led to some degree of scientific fatigue, I suppose, if one could call it that, because of the prolonged nature of the process. So it was quite exhausting, apart from logistically challenging. So I'll stop there on that point and hopefully it gives you some idea, but certainly happy to take questions on this or anything else.
Great. Thanks so much, Jon. And yeah, I commend you all for your ability to adapt amongst a changing world and no less to host an international conference for that matter. So I'm sure we'll have questions about the future process. I know you're probably still recovering from the 6th one, but I guess the 7th one is starting to be planned already, I'm sure. I can pass it to Adrian to discuss the actual new definition of sport-related concussion.
Perfect. Thank you, Reed. So in consistent with previous consensus statements, researchers have obviously updated the definition of sport-related concussion to reflect new findings and with hopes to guide clinical practice and furthermore the goal of ensuring that the definition is comprehensive, accurate, and reflective of the complex nature of concussion. Accordingly, these updates will not only help healthcare providers diagnose and treat sport-related concussions more effectively, but also help athletes, coaches, and parents better understand the signs and risks associated with this injury and take the necessary steps to prevent it. So in this section of this talk, we'll just kind of briefly explore the latest definition of sport-related concussion and compare it to the last definition found within the 5th consensus statement, which is displayed on your screen, with the 5th consensus statement definition on your left and the 6th on your right. And kind of doing a deep dive into kind of really understanding the terminology being used and comparing across definitions, it appears as though that they consider that modifications to the Berlin definition with a further understanding of the pathophysiology associated with sport-related concussion. In particular, it appears as though they specifically acknowledge that the neuroimaging studies and the work in the neuroimaging space rather as associated with consistent observations and changes in blood flow and cerebral metabolism may be associated or is associated rather with this injury. However, the absence of structural changes observed in neuroimaging studies might be a sort of exclusionary criteria for this specific definition of sport-related concussion. And finally, just wanting to kind of make another additional note is that it appears as though that the authors noted that this is certainly a conceptual definition it may not exactly provide the specific diagnostic criteria. And so, Jon, I think that we'd all be very interested in hearing how you and co-authors decided on the specific terminology used in this definition, and maybe even additionally, what sort of challenges do all of us kind of, or should we all kind of face when coming up with a definition for such an injury that has, at times a very heterogeneous clinical presentation.
Thanks very much for that succinct summary of the definition. So essentially what we did was two things when we looked at this definition. The first thing was we went back to Berlin and we said, are we that unhappy with this definition from a conceptual point of view? And as a group, we decided that after some discussion, we thought it was still a relevant definition. And so the changes that you've highlighted there are really tweaks which emphasize some of the important aspects, that it's short-lived, that we don't see it on standard imaging, that it may not involve a loss of consciousness. This concept of sport and exercise related is something that's coming into the discussion more and more in terms of what is actually a sport-related concussion. Does falling off a playground, jungle gym count, for instance? So that sort of thing is becoming more and more into the fold in terms of looking at recreational activities as part of this as well. And the issue of, the structural imaging is also a factor. You mentioned the operational definition, and one of the confusing things perhaps for people who read in this area is that there are different definitions. So one of the more prominent definitions is that from the American Congress of Rehabilitation Medicine, ACRM. And so we had members of our scientific committee actually interacting with ACRM over the months preceding the Amsterdam meeting. And we discussed merging our definitions. Theirs being very much more operational, very structured, much longer definition. But we wanted to try and unify our definitions. And we actually came very close. There were really just some distinguishing features in terms of some of the on-field presentations where we had slight disagreements. But I think that collaboration will continue. And hopefully as we get through to the next, close to the next consensus meeting, we'll have unified conceptual and operational definitions, which will hopefully take some of the confusion out of those definitions which people read across different literature and different organizations. So I think we made some advances, but overall we didn't want to change the conceptual definition too much, and so it remains pretty close to the Berlin definition.
No, thank you for that perspective. I think that, you know, as you know, certainly the trainee, you know, when we approach these different types of injuries, or when we try to investigate these injuries further, having a definition of you know, is the definition being applied in one clinical setting compared to another? And I think this standardization certainly helps, you know, myself as a researcher in identifying how different time periods have had a different definition, and how may have those injuries been diagnosed or evaluated in different perspectives. So I think with that, we'll move into our next block, which will be the injury prevention section. Reid? Great,
thanks, Adrian. So as shown here, primary concussion prevention, primary prevention being the prevention of the initial onset of an injury, in this case concussion, can really help reduce the burden of injury, risk of a recurrent concussion, and is associated with a lower risk of persisting concussion-like symptoms. The consensus statement thankfully notes a threefold increase in the past 5 years of studies examining primary prevention strategies in sport. Again, a promising number that ideally continues to grow throughout the years. So as we see on the left here, the three main domains in which primary prevention strategies are often studied are policies and/or rule changes, personal protective equipment, and training strategies or interventions. So an example of policy change that's popular with primary concussion prevention would be the banning of body checking in ice hockey for youth hockey players, or reducing contact practices in American football, which are both highlighted in the consensus statement to have very robust effectiveness in reducing concussion rates. Moving next to personal protective equipment, as you can probably guess, that includes things like mouth guards or headgear in non-helmeted sports. And finally, training strategies mainly were reported as neuromuscular training warm-ups in the consensus statement, and are shown to be effective in rugby, but further research in other sports is definitely encouraged and will be discussed in just a couple of slides. And finally, I just want to highlight a very promising number that I personally took interest in, was that over half, around 60% of all primary prevention studies included children and adolescent athletes. So I find that's a very encouraging statement. John, if you have any thoughts on that, do you think that's where most of the focus should be, is maybe those youth kind of getting things like technique down when they're young, for example, tackle training in rugby, say? Just wanted your perspective on if you think that primary prevention in youth is something that needs to be maybe not necessarily more focused on, but is it encouraging to see this number so high?
Yeah, I think you've summarized the key areas of prevention and risk reduction very well, as highlighted by the consensus statement. To pick up on your last comment, I would say, yes, encouraging that 60% of studies included children and adolescents, but nearly all of those are adolescent. So one of the weaknesses of our research is that we don't have nearly enough on 12 years and under. So that's an area that we really need more focus on. So if you're interested in research, that's a group to focus on, to give us the information that we need. So certainly, yes, encouraging and important, because this is the thing that parents are worried about. Are their kids at risk? Can their kids play contact and collision sports safer? What happens to them if they are injured? And are there strategies to prevent injury? And I think you've highlighted some very low-hanging fruit here, which I think we can all integrate no matter what sport we're involved in. So policy and rule change, I think, is critical. I think ice hockey's taught us a lot, and so has rugby, in terms of things like tackle height, in terms of things like body checking. Those rules have been shown to make a difference. And then that comes into policy around concussion management as well. Those sports that have better concussion management protocols have become safer. And so I think that's an area that administrators need to look at across all sports. The personal protective equipment, again, some low-hanging fruit here, mouth guards being one of them. Ice hockey's shown some very encouraging things, but we have the research that shows the protective effect of mouth guards on dental and orofacial injuries. So in any event, we can justify the use of mouth guards, and hopefully the research supporting that these might reduce concussion incidents will be forthcoming, as it has been in youth ice hockey. And so that's something that certainly things like sports like rugby are looking to make more and more compulsory. The training strategies, again, something that I think you can only benefit from: the neuromuscular training, the movement coordination exercises, things like neck strengthening as well. I don't think there's much downside to those. And as the research comes through that's more sport specific involving neuromuscular training, hopefully we see the benefits there. And the same thing with exposure, contact and collision exposure. It makes perfect sense that if you reduce exposure, as we've been shown in American football, that you're going to potentially reduce your risk and incidence of concussion. So I think that on this particular slide, you've highlighted some very critical areas that we should all be looking at in terms of introducing. And risk reduction is one of the key messages that has come through from the consensus statement, with some very pragmatic ways of implementing that. So thanks for highlighting them.
Great, thank you. Yeah, I think you summarized it very, very well. That's especially at the youth level, these three are incredibly important. I think especially highlighting maybe training strategies or policy rule change. I mean, you'll see now with football or American football or hockey or helmets, you know, they can run you upwards of $500-600 American dollars. So I think with things like NMT warmups, neuromuscular training warmups that have no cost, those are definitely easy to implement, all being important. But I think at the youth level, you know, when resources may be scarcer, it's important to have all three considered. Thank you.
Agreed.
So, Reed, just before we go on to the next slide, we have a couple questions here from the audience relative to the definition. So one individual was asking, does the distinction of the sport-related mechanism of injury really make a difference in the management? And then another question asking, at the conference last fall, there was mention of definition would potentially include a new time limit for the onset of symptoms. For example, maybe within the first 24 hours. Is there a reason that the time limit was not included in the new definition?
Yeah, those are both great questions, Steve. I think in terms of the mechanism, it's certainly in terms of sport and exercise and recreational activities, it's becoming more and more blurred. You know, what about motor vehicle accidents and that sort of thing? I think certainly there's a huge degree of overlap, and particularly as our assessment protocols, as we'll discuss in the coming slides, I'm sure, have become more robust and multimodal. Those approaches become more relevant across different causes of concussion. So I don't think it's isolated to sport related. I think because of the profile of sport and because of the deliberate choices to play sport and some of the consequences that follow, sport-related concussion has received particular focus, but it doesn't mean at all that it's not relevant to other causes of concussion. But the mechanisms, I think, that being sport and exercise related, have created a niche for the definition. In terms of the time frame, 24 hours, you know, I don't think there's particular evidence that suggests that 24 hours should be a cutoff. Number one. Number two, we know that many athletes may present after 24 hours, either because their symptoms may have evolved over time, and secondly, because they might not have had the medical support initially available to them. So I think it's perhaps risky to put a threshold at 24 hours. That might be pushed out, for instance, 72 hours to cover more of the evolving concussions. But there was no agreement on a time frame, and to be honest, beyond those questions that were asked at the meeting, not a lot of discussion, because I think we want to encompass more potential concussions rather than fewer, and by putting a threshold on them, a time threshold, we might miss some of those. So certainly something to be discussed going forward, but I don't think 24 hours, symptoms within 24 hours is necessarily an appropriate threshold based on the information we have at the moment.
Great, thank you.
Great. So thanks, just kind of jumping all over the place, but back to prevention, I just want to quickly highlight what I think really epitomizes the purpose of the statement. So just underlined here, we see in the 5th consensus statement published 2016, I believe, with Berlin, we see the evidence of mouthguard use in preventing sport-related concussion is mixed, but we, would like to see further studies, further rigorous case control designs. And if you wouldn't mind going to the next slide, Adrian, please. We see that the research kind of caught up to our thinking, and that we see that due to this strong and rigorous research, that mouthguard use is supported and should be mandated in child and adolescent ice hockey. So I just wanted to highlight that because I thought that was very encouraging to see how we go from saying, well, evidence may be mixed, to saying, okay, we have enough robust evidence to promote these practices. So I just wanted to highlight that for prevention purposes. Next, we're going to move on to the new and shiny SCAT-6, so the Sport Concussion Assessment Tool 6th edition. This is moving from primary to secondary prevention, in which we aim to identify concussions. So the new SCAT-6 will undoubtedly be used worldwide in both adults and children, with the child SCAT-6 intended for those under 13 years old. So we do see components that are similar in the SCAT-6 compared to the SCAT-5. We see immediate on-field assessment followed by an off-field assessment, ideally in a distraction-free environment, but if we have any athletic trainers on the call, we know that may be difficult sometimes. Again, we see the 22-item symptom evaluation, standardized assessment of concussion, and so on and so forth. I will highlight the key points that you can probably see on the right side there of the SCAT-6, that, again, this is not a diagnostic tool. This is aimed to assist in these clinical evaluations of sport-related concussion. Be sure to check for red flags that may necessitate immediate medical attention or hospital transportation. And, of course, anyone suspected of sustaining a concussion should be immediately removed from play. So just on the left side, we see the some components of the SCAT-6. And on the next slide, we'll highlight kind of the differences, at least with the scoring. So, and by the way, at the top middle of the slide, I just put a QR code for the new SCAT-6 if anyone's hasn't been able to see it yet. So, as mentioned previously, we have similar components, but I just wanted to highlight at the bottom of the SCAT-6 scoring, we have a new timed component for the tandem gait, and also an optional dual task assessment that is timed. So ultimately, from the SCAT-5 to the SCAT-6, we do see a lot of similarities, but there were some recommendations added to the SCAT-6, including removing the 5-word list due to a ceiling effect, creating a cognitive composite score, just to improve test-retest reliability. We see adding a time component 2 months backwards, and others that you can view for yourself. And also, which I would like to highlight, was adding a more robust set of visible signs to the SCAT-6 tool, including falling with no protective action, tonic posturing, impact seizure, etc. So next, after the SCAT-6, we kind of have its cousin that I think John's probably excited to talk about, the new SCOAT-6, so the Sport Concussion Office Assessment Tool. So as Dr. Patricios led this, I'm hoping to hear his thoughts on the birth and development of it, but I can just give a little bit of a background. So the SCOT-6, as opposed to the SCAT-6, is intended to be used after 3 days up to weeks after initial injury. So we do see similar components compared to the SCAT-6, but we also see more clinical assessments, such as measuring of blood pressure, cervical spine assessment, and then we see neurological examinations, so on and so forth. So Jon, if you don't mind, I'll kind of turn you loose here, and maybe you could give us a little bit of a background of how the SCOT-6 came to be, as this is a new tool. Was this always an aim of the group from previous editions, or if you could just give us a little rundown of how this new tool came to be, please.
Yeah, again, you've given a great summary. So just to go back to the SCAT-6, and you mentioned that there weren't that many material changes, and that was quite deliberate. The reason being that the SCAT-5 has been validated in various settings, that there's a lot of research that's gone into it. And for that research to be comparable and longitudinal, the panel felt quite strongly they didn't want to change most of the components significantly. So those changes are small upgrades, really. There are additional tests which are added, but most of the tests are remaining in place as they were. So the reason is for comparison and research going forward. Over time, and I'm sure many of you as clinicians have appreciated this, that the SCAT-5, as we knew it, has limited utility. We know that most components outside of the symptom checklist are only validated for use in the first 72 hours. Many of us evaluate concussed athletes beyond that, either as a follow-up to their acute evaluation or because they present later. And so we felt that a more robust and clinically appropriate multimodal evaluation was really needed. And these discussions took place over some time. As clinicians thought about this, we decided to include it as a systematic review to look at which components of the SCAT-5 and which components of clinical tests outside of that might be relevant and validated to use in a more multimodal evaluation. And that's where the concept of the office assessment came to be. And so we included a systematic review, which you will see included in one of those 10 reviews, which looks at those clinical components. I think we are where the SCAT-6 was 12 or 15 years ago in terms of creating an initial tool, which I'm sure will undergo some changes in the years to come. But essentially, the SCOT-6 looks at a more robust and extensive history taking in terms of current history, mechanism of injury, and then also those modifying factors which might influence concussion outcome, both physical, neurological, and psychological. It includes many of the cognitive measures that are in the SCAT-5, so that makes a comparison with the acute measures quite useful. It includes orthostatic blood pressure and heart rate measures, a C-spine assessment, the neurological exam, and then it includes gait and balance assessments, including timed components, single and dual tasks. And then it includes, which the SCAT-6 doesn't, the VOMS assessment, or a form of the VOMS assessment, the modified vestibular oculomotor screen. There was some discussion as to whether to include that in the SCAT-6. It was thought to be slightly too complex and time-consuming to include in a potential field-side assessment, and so was pushed out to the office assessment, which I think is appropriate. And then, as part of the SCOT-6 as well, importantly, some screens for anxiety, depression, and sleep, which can overlap significantly with concussion presentations, and then some reference to an exercise stress test as well. So the SCOT-6 is potentially the most comprehensive tool we've had thus far in evaluating the concussed athlete. And because we appreciate that clinicians have variable time available to them we have color-coded both the SCAT6 and the SCOT6 to include those components which we think are preferable to include every time you do the evaluation, and those which are sort of nice to haves. So a lot of thought has gone into it. There's also a much more comprehensive instruction list which is available to support both of the tools. And again, important to note that there are tools for the child assessment, 12 years and under, for both the SCAT6 and the SCOT6, which have been well supported by our pediatric colleagues as well. I see we have a question that's cropped up about change from the 5 to 10 word recall and the decision regarding that, in particular for youth and adolescents. Well, essentially, the research has shown over the last 5 or 6 years that for adolescents and adults, there seems to be a significant ceiling effect for a 5-word list, and that to make the test more robust and meaningful, that a 10-word list gives you more scope to detect any sort of cognitive deficiencies. And so it's really based on a lot of work that was done by Ruben Ekemendia's group in particular, which showed that the ceiling effect comes into play when you use a 5-word list. So for adolescents and adults, the word list has been changed to 10 words on that basis. So I hope, without going into too much more detail, that gives you some background as to the value, hopefully, we think the SCOT6 will add. Again, as with all the components of the consensus paper, we hope you'll read the supporting systematic reviews and also the instructions that support these tools.
Great. Thank you so much for that insight. I know it's a lot of ground to cover in a short amount of time, but I think you summarized it very well. So moving from the SCOT to the return to learn and return to sport strategies, I'll let Adrian take it away.
Perfect. Thank you, Reed. So it's very much apparent that, in addition to the physical symptoms that can accompany concussion, such as headache and dizziness, that students can experience difficulties with memory, attention, and processing speed, which naturally these symptoms can make it challenging for athletes, student athletes in particular, to return to the classroom and return to their academic work, which consequently might predispose them to a greater risk of falling behind and hindering learning. As such, it's essential to have a strategy in place to support these student athletes as they return to normal academic performance after their concussion. And without such support, again, may struggle to keep up with their studies, which can have detrimental effects on their academic performance and future prospects. And so within this block and the subsequent slide, we're going to spend some time looking at the return to learn and return to sport recommendations. But starting with the return to learn, authors note that, it's much like the return to sport, that it follows a certain graduated or gradual return to academic performance, or their normal academic performance rather, and hope that, educators may play a greater role in facilitating this recovery, this component rather of the recovery process. By understanding the intersection between sport-related concussion research and clinical practice and education, we can certainly work together to support these students who have experienced sport-related concussions to both help them succeed academically and athletically. And so, John, I think that, one of the things that, as a trainee and a researcher in this space, I'm curious to know that what are some of the bigger challenges you and your authors experience when writing about the return to learn strategy or policy or recommendations rather?
I think the biggest challenge really is a change in mindset. So for me, one of the take-home messages from this consensus process is don't cocoon the athlete. And so that means in terms of activities of daily living, and in terms, it reflects our new thinking about returning to classroom exposure environment, and also returning to work, as well as returning to exercise and sport. So for years or even decades, we've said, look, you've been concussed, let's protect the brain, total rest, cognitive and physical. And the research that's come out has shown that the consequences of that are actually negative. So if one cocoons an athlete after concussion, the return to normality is actually delayed. And so what this return to learn strategy provides is a very useful tool to share with patients and their parents to say, we actually want to get you back as soon as possible. And the research shows that if you expose yourself gradually and progressively over the days following an injury, you can actually get back to high levels of function without any accommodations and additional support in nearly all situations. And so the challenges are really a change in mindset, and also I think in addressing anxieties around exposure to a learning environment again. So what this sort of strategy gives you is a stepwise approach to say, listen, based on the research we have, we can talk you through these 4 steps and actually get you back to school, to the classroom in a reasonably short time frame. And I think it gives patients and their parents a lot of confidence to know that they can get back and that they have a systematic approach to doing that. And if you don't do this and you overprotect and you cocoon athletes, I think a lot of anxieties are created around the process. And having a structured format to turn to helps alleviate a lot of those anxieties. And of course, there will be children that require support and accommodations, and we can provide those. But if you follow a stepwise approach and you set them these goals, I think that a lot of those anxieties are laid to rest. So I look at the return to learn and return to sport strategies as additional tools that we can use similar to the SCAT and SCOT. And we can utilize these in nearly every one of our concussion situations. So I think the group that analyzed this and came up with it has done a great job.
Absolutely. And, I think that looking at the return to sports strategy, which we'll get to in just a second, noting that, the return to ways to promote return to learn, including environmental adjustments or curricular adjustments and testing adjustments to kind of ease and reduce the amount of anxiety associated with having a cessation from being able to, learn and perform their academics in a way that they want to.
Adrian, just before we go over to return to sport, we've got a question here from the audience asking if there have been any updates in regards to the return to learn protocol for students with learning or mental health concerns. So, for example, someone with ADHD.
Again, that's an outstanding question, and it's something that we face often in a learning environment. So the answer is a broad one, and that is that your approach should be individualized, that there are research studies now which support the assumption that we've had that ADHD, depression, anxiety, other mental health issues may impact on the presentation of the concussed athlete and also their recovery. And I think it's important to have that discussion with athletes who have those conditions, say to them that we take them into account in both their evaluation and in terms of how we'll progress them through the stepwise process, that it may take a little bit longer, that some of their symptoms may be as a result of those pre-existing conditions and not necessarily concussion related. And that's important, not to label everything as concussion related, to put it into context, have an open discussion and say, listen, there's an overlap with these symptoms, and we think that some of them may be pre-existing, but we certainly acknowledge them and we know that they're going to be taken into consideration. And if one follows this sort of stepwise process, then I think it allows for those a broader approach that takes into consideration some of those pre-injury conditions, which might be modifiers in the process.
Great. Thanks, Jon.
And so moving right into the return to sport strategies, again, kind of displayed in front of you are the return to sport strategies as a part of the 5th consensus statement. and likewise the sixth consensus statement. Now, I think I just highlighted at least two sections or two blocks rather from each that kind of stuck out to me the most as far as being expounded upon, supported by recent advancements in looking at how early administration or of moderate or vigorous physical activity might be associated with certain recovery strategies that might aid in returning that athlete back to full competition levels. So I think that one of the questions that I had that kind of came out of looking at both the return to learn and the return to play protocols was that, within these protocols, there's a 0 to 10 symptom scale, while the SCAT-6 uses the 0 to 6 scale. I was wondering if you were able to kind of speak to why the difference persists or exists rather.
So I think a few important things to emphasize about this return to sport process, again, quite critical to the message coming out of the consensus statement. The first is that exercise is actually beneficial early in the process. So again, moving away from this cocooning concept that 48 to 72 hours after injury, one should introduce very sort of deliberate exercise as an intervention, and that people that do that seem to recover better. In fact, John Leddy's meta-analysis showed that those people that incorporate exercise early in the process actually reduce their return to sport time frame by an average of 5 days. So that's the first take-home message, that early exercise is beneficial. The second is that we don't have to wait for a patient to be asymptomatic to introduce exercise, that we tolerate, that they tend to tolerate exercise incorporated early on, even if they have symptoms, as long as those symptoms don't result in too much symptom exacerbation. And that's where your question about the point scale comes in. So it was an area of discussion in terms of, is there some confusion between the symptom scale on the SCAT being 0 to 6 and the exacerbation of symptoms related to the return to sport. And it's a slightly different scale. So if one looks at symptom exacerbation, you'll often, traditionally rated on a 0 to 10 scale, and that's what this refers to. So not so much the rating of all of those symptoms. It's on the SCAT symptoms, it's really a 0 to 10. How would you rate your pain today? How would you rate your headache today, etc. On a 0 where there's nothing, and 10 is I really can't stand it scale. Whereas it's slightly different to the scoring used on the SCAT-6. So there was some discussion as to whether we should do it all on a 0 to 6 scale, and John Leddy and his group felt that because they had done some of their research on a 0 to 10 scale, the symptom exacerbation should remain scored on that basis, showing the patient a chart of 0 to 10 and asking them to score their symptom exacerbation on that basis. So it is a potential area of confusion, but ultimately you're asking if their symptoms are increased by a level of 1 or 2 maximum to allow them to continue with that level of exercise. The other point I'd like to emphasize is that the return to sport chart, as it's tabled in the consensus statement, the first 3 stages actually allow for symptoms and symptom exacerbation while introducing exercise as an intervention. The next stages necessitate the patient to be symptom-free. And that's the block that you've shown there in red there at the bottom right, to emphasize that at those first 3 stages, the patient may be symptomatic and exercise is deliberate, but when they move to the sport-specific stages and certainly to the contact stages, they need to be symptom-free. Also, just dealing with some of the questions that have come up, I see on the Q&A around the exercise intervention. The Buffalo treadmill test, why is it included as an intervention when it's perhaps not practical for some people to include, some people may not have training on it, and referral to an athletic trainer or physical therapist may not be appropriate or viable in certain situations. The Buffalo treadmill test was included as a validated tool. A lot of the research, as you know, has been done on the Buffalo treadmill test. But I think the take-home message is that as part of your return to sport protocol, there should be some sort of exercise stress test. So whether one includes it as a formal Buffalo treadmill test or one constructs a test where there's graduated increases in exercise exposure and load, one of the final stages should be some sort of exercise exposure that's graduated. It just happens that the Buffalo treadmill test is validated, and it's a reasonably easily applied test in many situations where you have a treadmill and a bicycle available. As you know, there are field tests which are comparable to the Buffalo treadmill test. So I think one needs to individualize the approach to the particular clinical context. That's the take-home message there. Other questions that have come up related to the return to sport protocol. The note before steps 4 states that 4 to 6 should begin after resolution of symptoms. What's the definition of abnormalities in cognitive function? What's the definition of that? Well, I think ultimately that the principle here is that return to learn should precede return to sport. So the priority in a young athlete most often is for them to get back into their learning environment. So before getting them back to sport, they should have optimized their return to learn strategy and moved through that before they're re-exposed to sport. And the stages 4 to 6 should usually occur after they're back into a return to learning environment. Essentially, if they're still struggling with a cognitive return, they're not symptom-free, and one needs to address that and utilize the return to learn strategy in parallel with the return to sport strategy. So that would really be the take-home message there. And then what are the considerations for clinician application of the CISG statement when managing concussion in populations underrepresented in the literature? This is a huge area of significance. Okay, female athletes from under-resourced communities, they really need the extra support that perhaps resourced communities don't have. And one of the questions we tried to answer is, how do we utilize the tools and the strategies to support these groups? So one of the key areas is that under-resourced communities don't have access to a lot of support, either logistical or in terms of equipment. And so the tools and the return to learn or return to sport strategies ideally can be applied without extra resources. So that was a central theme that we tried to apply. What we need to challenge ourselves moving forward is, how do we better research these communities? Female athletes, I've spoken about the younger athletes in under-resourced communities. Most of our research comes from North America, and we need to try and better support collaborations outside of those better resourced areas. So it's a challenge that we need to try and better address before the next consensus meeting.
Jon, thank you for all of that, and that's certainly something we'll certainly take to heart. Steve, I think we're going to pass it over to you as we wrap things up.
Yeah, so great discussion by everybody, and unfortunately we're out of time and not gonna be able to get to the last couple sections, but really, Jon, thank you so much for joining us today and fighting through some technology issues there at the beginning. Appreciate your time. Thank you to our audience for taking some time out of your day to join us. Really appreciate you guys dialing in and the robust questions that we had. To learn more about the University of Michigan Concussion Center, please find us at concussion.umich.edu. Or you can join us on what is formerly known as Twitter at UMich Concussion. Thank you to everybody again, and have a great day. Thank you.